try it in the gym.
Phil wants to study it. All right. So this is great. We have what we don't usually have, which is we're ahead of schedule. We try to stay on schedule. We are actually ahead of schedule, which is great. So we can work towards vitamin D and sunshine, shopping down that way. You can spend lots of money, very expensive groceries or department stores down that way for those who haven't been over there. So we're going to stay with our neurocognitive theme, the HRSA project for this afternoon. And we had talked about the evolving science of evaluation of neurocognitive impairment as one of the things that we wanted to learn more about, because it is rapidly advancing. It's advancing faster than our ability to treat and cure these conditions. So this is a little bit future world, but the topic that we wanted to talk about is the approach to using imaging. So you saw in our case discussion this afternoon, our colleague from Norfolk was describing MRIs and pointing out the coronal sections of the case, that we showed where the amygdala on the one side was lost from a stroke and the amygdala on the other side was shrinking. How much of that sort of thing are we going to do? And then past that, there are newer technologies. So we had lined up a speaker to come and talk to us about that. She had a family emergency, very sad situation, and had to back away. And at the last minute, I reached out and found somebody else to step in who was generous enough to put together a talk for us. So we're going to bring up Dr. Jamal Zweit. He's a PhD, professor of radiology, radiation oncology, pathology, biochemistry, and molecular biology and chemistry. It's a mouthful. Director of the VCU Center for Molecular Imaging, internationally recognized for his work in molecular imaging and drug development, and conducted the world's first molecular PET imaging clinical trial of anti-angiogenic therapy. Studied radiation biophysics as an undergraduate at the University of Kansas and obtained his PhD from the University of Manchester in the UK. So there is some amazing technology for looking at brain pathology without taking people's brains apart, which used to be, there's some downsides to that, and oftentimes difficult to find volunteers. So to bring Dr. Zweit up, I'd like to introduce a brief video.
Suppose it were possible to transfer from one mind to another the experience of another person.
Hey, there it is.
Any person, any experience.
I'm telling you, it works.
The test, sound, taste?
Everything,
Smell.
everything, 100%. In fact, better.
Did you have a breakthrough or not?
Yes.
I'd like a demonstration. Knock my socks off.
Good afternoon. Thank you, Peter, and thank you to the Society for inviting me to speak to you this afternoon. I'm not a clinician by any means, but I'm what you call a clinical scientist. So I'm a PhD. We do a lot of research, particularly in molecular imaging, in cancer, in neuroscience, inflammation, and other conditions. So I'm at the VCU School of Medicine, and I direct the Center for Molecular Imaging. This has been established about 8-9 years ago to provide a dedicated research facility to do preclinical and clinical translational research that involves multimodality imaging, which requires a lot more than what you do with your standard of care in terms of X-ray, CT, or structural imaging. In addition to that, I want to also mention that a few years ago with Dean Jerry Strauss, we established a new facility in downtown Richmond that's dedicated to clinical research in terms of imaging. Because a lot of people who want to do clinical research, they find it very difficult to use standard of care facilities with the radiology departments because they are basically busy with their service work. So this facility has been established specifically for clinical research. So if you're interested in conducting neuroclinical research using MR technology, and this facility really offers sophisticated ways to look at different things, looking at chemical metabolite analysis, to elastography, to functional MR, and other things. So if you need any more information about that, do feel free to contact me, and I can direct you to the right people to look at that. So that's a good facility, I think, that for clinical research interested people can really tap into. Okay, so imaging in general has a role in neurodegenerative disease, in dementia and other forms. And what we want to show is how do we combine these different modalities, structural modality, looking at the anatomy, physical changes that happen, as well as functional, not necessarily specific function, but underlying functions, such as metabolism, such as blood flow, etc. And then we take it further to the molecular level, where we look at specific things that are entangled within the disease of Parkinson's or dementia, such as tau, amyloid plaques, etc. So those require specific ligands, specific material that will only bind to these things and can give us a picture of what happens or how these things change from a healthy state compared to a dementia or a pathological state. And the aim or the overall goal is really to understand more of the biology, what's really going on. And that, we hope, that will accelerate the development of new therapies, maybe individualized therapy, maybe precision-based medicine. So this is the really whole goal of understanding why we need in vivo molecular imaging. Now, you can only do so much with samples, whether it's post-mortem or biopsy or etc., because you're only looking at a sample. You're not looking at the overall picture. This is what in vivo imaging allows you to do. We can look at things at the same time. If we were to use the analogy, for example, of biopsies or taking samples, then we have to poke so many places in the body to receive that information. And that's not possible, of course. So here is the power of molecular imaging, where we're actually studying biochemistry and neurobiology, or cancer biology for that matter, but non-invasively and without taking samples, but of course looking at the scanning and the imaging technique that you use in whole body. Okay, so we can define or we can categorize imaging into three different classes. We can look at structural, looking at the anatomy, physical change. And here we are basically looking at areas that have changed in terms of size or shape or morphology, for example, atrophy, ischemia, etc., things that can be induced as a result of that. We can go further and look at some of the underlying functional features that eventually result in the physical change. This always happens before this. Okay? So here we can look at some things that are non-specific. For example, we can look at blood flow, and the major compound that's used in the clinic today is a lipophilic technetium-99M HMPO compound and SPECT imaging. So this is basically a short-lived tracer that will get diffused upon intravenous injection with the blood flow because it crosses the blood-brain barrier as well because of its great lipophilicity. We can also look at, one can also look at metabolism. The brain uses sugar to produce energy. So hypometabolism is a feature of a lot of the neurodegenerative diseases. And FDG PET, particularly FDG PET CT now, where we combine PET with CT in one machine, is really making strides, and it's one of the standards of care that's part of the functional imaging armamentarium for looking at dementia. The third thing we can look at is we can look at what are the neurotransmitters that could be involved in these diseases, such as dopamine. So we could look at dopamine activity with a compound like iodine 123 labeled ioflopane. So this has been sort of approved a few years ago to look at dopamine activity. The third class, where we can go more sophisticated, is where we look at the biochemistry or look at the neurobiology that's involved or underlying the disease. And here we have radio tracers. This is only done by either PET or SPECT. It's not done by MR or CT because we are actually looking at a chemical interaction that's happening between a radio tracer and its target. And that target could be amyloid plaques, it could be tau proteins, or it could be something else. So here we use specific radioligands that are labeled with a positron-emitting tracer in order to allow us to look at this function. In addition to those, which are features of the dementia process or neurodegeneration, neuroinflammation is very important. And that happens quite early on because the stimulus, whatever it is for the neurodegeneration or for traumatic brain injury or anything like that, is followed by overexpression of immune cells that will result in an inflammatory process. So those could be a target as well. And I'm going to show you some examples of some radioligands that target that process specifically. Okay, so let's talk a little bit about what do you do first, which is first-line structural imaging. Now, because of availability and ease and logistics, X-ray CT is still sort of the main standard of care with the coming of more anatomical and structural MR imaging. So the main thing that people do when they request such things is they want to rule out other things, hemorrhage, tumors, etc. So that's really the main reason that people look at the initial thing. And here we have three different sort of examples where we can look at the large ventricles, in this case of hydrocephalus, for example. We can look at some abnormal hemorrhage in this plane, or we can rule out something like meningioma that's also happening here with this particular CT and MR image. So that's usually the main thing or the main indication that people ask for these kind of images. Okay, so we could go further and look how we can combine both MR and CT to look at the progression of the disease, for example. Okay, so here we are demonstrating hippocampal atrophy, characteristic of early Alzheimer's disease. When the disease gets further, we can see the larger involvement of these regions in this particular CT tomography thing. So we can use two different techniques at different stages of the disease and try to elucidate or show what are the structural anatomical changes that are happening during this period of time. So the other example is where we can differentiate between maybe different types of dementia. Here we have hyperintensity on a T2 MR image with vascular dementia in this case. In the middle panel, we have an atrophy in an axial MR flare as well. This is basically in frontal lobe dementia. We also look at some features that are characteristic of dementia with lower bodies, for example. So this is a structural but not complete diagnostic differentiation of these three cases. But you could use it as a baseline in conjunction with other methods to try to differentiate between these things. And that differentiation is not always or it's important when we're trying to treat that patient versus that patient versus that patient, or try to devise a treatment modality that works for one subtype compared to another subtype. Okay, so going from structural and anatomical imaging, when should physicians like yourselves order or request functional imaging assessment? So you do that to differentiate between non-dementia, so or AD, or vascular AD, or frontal lobe. You could use FDG PET-CT. Now this is a technique that uses two modalities. Uses the functional technique of positron emission tomography combined with an excellent anatomical resolution technique such as CT. So 2 in 1. When I did my PhD, this was not existent. In fact, my advisor, or my PhD advisor, was the inventor of the PET-CT technology, Dr. David Townsend, some years ago. We can also then look at which one gives us the sensitivity and specificity that we are looking for. And the research so far shows that FDG PET-CT, which shows hypometabolism of brain activity, is probably more specific than just doing blood flow imaging with technetium HMPO. The same tracer is basically very widely accessible. That's why a lot of people use it. FDG PET is not as accessible as SPECT imaging because it uses short half-lives. You need the proximity to a production facility that makes these ligands for you. While with these things come in a kit formation, you just buy a generator of molybdenum and technetium, and you milk it whenever you need it, and just do shake and bake radiochemistry to prepare that kind of molecule. Dopamine activity can also be looked at with another tracer. This is developed some 15, maybe 20 years ago, and the tracer reflects the dopamine transmission activity that can be attributed, or the binding of the tracer to dopamine activity can be attributed to how specific and how sensitive it is. And these are pretty specific and pretty sensitive up to a point. But we can see later when we go to the molecular imaging paradigms that we can accept or appreciate how we can even really tap into the neurobiology of what's going on in neurodegenerative diseases. Okay, so here is some interesting examples using the both HMPO and FDG PET in AD. So as you can see, we can look at a healthy brain where the distribution of the tracer is pretty much sort of uniform. When we look at a patient or AD patient, we have a hypoperfusion defects in some of these areas, as you can see. So with this kind of scan, white is the maximum uptake or the maximum tracer uptake, and then you go to blue and so on, that's the small amount. So as you can see in the normal brain, there is more uniformity in there. Here we see some defects as well as here as part of this Alzheimer's disease compared to a normal brain. Mostly in the temporoparietal region for that particular case. So that picture can also be matched with the activity of the dopamine. In this case, this is the dopaminergic SPECT imaging with the I-123 alpha fluorine. This is a normal brain, and you see how the ventricles look like. You see how the abnormality here with a deficient uptake or less uptake in the AD patient compared to the healthy person. Okay, so I came across this article, and I think it's very interesting, and I want to share it with you. And of course, it's relevant to what you do, because one of the things you want to do is when to request these things, or what are they, and what questions are you going to ask? Is it going to be beneficial to me? Is it not? So this is an interesting article. Came out as a study that's done in Ireland and Wales in the United Kingdom, and I thought it would be useful to look at some of the data from this study. So the study asks a number of questions. And one of the first questions is, what's the importance of neuroimaging in the diagnosis of dementia? So as you can see, in both categories, most people think that it's important, maybe somewhat important, but they don't think it's unimportant, or less of them think it's unimportant. And somewhere in between, it's very important. And I think this is partly due to the lack of knowledge of what you can gain with these techniques. So, and it depends on the geography where you are in the world. In Wales, they don't have as much scanners as they do in Ireland or in England or other sort of European countries. So I think this is a reflection of that. The second question is the reported availability of neuroimaging modality for direct referral. So again, you could see how in Ireland, for example, most of the things are done with the CT and followed by MR, and then with nuclear medicine here, what they mean is probably PET and HMPO SPECT, if you like. In Wales, this is mainly less because of the non-availability. Wales does not have the same type of facility as in Ireland, but I think that shows how availability is also a factor in determining how people should use these techniques. Okay, the reasons for reporting or for referral of neural imaging. So there are a number of questions asked. So for patients or person less than 65 years of age, there is more reported reason, or there more reason to do that compared, say, to for clinical guidelines, or try to determine subtype of dementia where you use neuroimaging as less. You still use it, but you have to rely on other diagnostic measures to really come up with a more definite diagnosis or differential diagnosis. So this is, I think it's interesting to show that why different reasons are used to request neuroimaging in the studies. So people were asked also, how confident are you in selecting the most appropriate neuroimaging modality? So there are not a lot of people who say they are very confident, and I think that's because there's not enough knowledge that people appreciate. What can they get out of it? What are we sort of looking, and what can I combine it with as well? So most people are either not very confident or somewhat confident in terms of why they are selecting these techniques for neuroimaging in dementia patients. Yeah, the other thing is understanding of the neuroimaging in dementia. As I just mentioned, a lot of people feel very confident, or not a lot of people feel confident in understanding what's going on. Most people are either not very confident or somewhat confident. That's why they shy away sometimes from requesting or ordering these kind of supplementary study to other measures that physicians do to diagnose patients. Okay, and they were also asked, how important is it to further your knowledge about these things? And I think there's in Ireland, as opposed to Wales, it's very important, for example, and that's because I think the expertise and the infrastructure that's available in this country compared to this country is more there. So there's more awareness in that sense. A lot of people think that it's important or somewhat important to further their knowledge. And I think this comes with a lot of tools and a lot of avenues where people can gain more knowledge in these cases. Okay, so we'll turn now to, as Peter mentioned earlier, to the recent stuff, the molecular imaging stuff. And when we say recent, we started working on this like many years ago, 10, 15 years ago. And one of the first things that have been developed is what we call the Pittsburgh compound. So this is a carbon-11 labeled molecule that binds to amyloid plaques, which build up during the dementia or the neurodegenerative process. So this particular molecule did not go very long in terms of adopting it as a conventional or as a standard of care clinical for two reasons. The first reason is this is a 20-minute half-life radiotracer, which means that you have to work against the clock. Okay? Every 20 minutes, you lose half of it. Okay? So, and therefore, it requires what we call a local cyclotron, a machine that you have in the hospital, like what we have at VCU, that produces the carbon-11 for you. And then from there, it doesn't finish there, then you take that carbon-11 activity and then use it to synthesize or make the drug, make the compound, okay? And you have to do this within the hour, 1 to 2 hours maximum, and the patient is waiting. So the logistics of this is not easy. It requires a lot of infrastructure and stuff and so on. So, but nevertheless, we could see here's an AD person, this is the control. Red is the maximum amount of uptake that you see from the radiotracer. So in a normal or in a control person, we don't see much uptake, very little compared to an AD patient. And we can see that both in this slice as well as in here. So this is one of the first things that's been developed to look at amyloid plaques in neurodegeneration. Now, because of the limitations that I mentioned, so then people started to develop alternatives to this. Use the same binding molecule, but label it with a more logistically easy to use tracer, like fluorine 18, longer half-life, and it does not have the complexity of instability in vivo. Most of carbon-11 compounds, they do degrade in vivo, and you have to do a lot of corrections, et cetera, et cetera. So it's not really tailored for a clinical diagnosis or clinical workflow as such. Okay, so you can go even further with MR, for example, looking at atrophy. In the old days, we used to look at atrophy just manually. This is bigger than this, so this is smaller than this. So since then, there were a lot of techniques, voxel-based techniques, that allow you to do accurate volume measurements in different cases. And here I'm just showing some examples of hippocampal atrophy. Basically, is a risk factor for cognitive decline. So this is proposed that this can be used as a functional but more analytical technique as a biomarker for the disease. So we've gone away from manual developments to more sophisticated voxel computer-based methods that gives us more accurate reduction in volume. Also, it can also look at the rate of reduction, because I think the rate is also just as important. Okay, so we can look at the extended sort of blood flow with the technetium compound as a result of, as an indicator of pathology and atrophy. But more than that, so when we highlight these different defects and so on, we can put it on an atlas map of the brain with some MR as well. And then we can match the tracer uptake with areas that are blue or green where they have that defects. So here, taking advantage of two modalities, but use both of them to gain as much information as possible, or try to reduce the uncertainty of what's happening with these things. Because most of the radionuclide-based techniques don't have good resolution. They have the good specificity and sensitivity, but they're lousy in terms of resolution. That's why I have to superimpose them into CT or MR or things of that nature. Okay, as in this example, so we have the GPET superimposed on T-weighted MR, where we can see the hypometabolism or reduced uptake in the medial temporal lobe. Now, before the advent of PET-CT, this is what we used to do, superimpose, just co-registration of images. Now we can do this whole picture in one system that gives me the anatomy and the physiology in the same picture. Okay. We can also look with MR at some enlargement of perivascular, particularly with T2 imaging in here, and we can see, as you can see with the arrow here and here, This is the sagittal image on the MR, T1. This is the T2 image. So T1 and T2, one gives you hyposensitivity, the other one gives you hyper density, if you like, so black and white, blackness or white. So this is another way of looking at the perivascular spaces using the same imaging technique, but two different protocols, two different acquisition protocols, if you like. Okay. Similar thing, we can look at hemorrhage with P2. You can see here. Okay. And this is great. This is another pulse sequence called gradient echo MR imaging. So these are not standard of care, but these can be done upon request, depending on the condition or the questions that we're trying to address. Okay. This is the dopamine compound, where we show, again, normal ventricle uptake in these and diminished uptake in the case of AD, Parkinson in this case, which is particularly the subtype of dementia Lewy body. So this kind of technique can distinguish this from, for example, frontal dementia or from vascular dementia as well. Okay. Structurally, MR can also be used to look at vascularity. Okay, so we can determine tissue vascularity. And here we can see in the first panel, for example, we have extensive white matter lesions, greater than maybe 25%. And this is using this particular technique. We do the image and we do a protocol called the recovery image to determine the attenuation map and give you attenuation inversion recovery image. That allows you to do things like this in here. In the second example, we have another large cortical infarction that's been detected using the same inversion recovery image sequence. We can also look at bleeding, as we can see in these two examples here, using T1 and T2 techniques. So when you talk about MR, there is so many different subcategories depending on the type. We're still looking at function, we're still looking at spaces, but we can use different techniques that allows you to measure one parameter versus another. So to go more sophisticated into that MR vascular map, one can do immunohistochemistry, where we have an antibody specifically for that particular pathology. And here, for example, we can look at my infarct in the cingulate. You see this area here? This is all the normal immunohistochemistry. So this is basically the histology of the tissue, or for the image area of the tissue. In the second one, we're looking at also infarct in the frontal cortex. For example, this is the slice corresponding to that. And here we're looking at bleed, as well as an infarct in the frontal white matter as the second one. So these images match those areas on the MR vascularity map in order to further validate that the pathology is giving me this. I'm not just relying on the image, but I'm validating it with immunohistochemistry pathological study. Okay, so the future or the recent ongoing research is really in PET radioligand neurochemistry, where in addition to looking at FDG, so the interest is to assess the status of amyloid plaque formation, tau proteins, how are they different from one subtype to another? How are they different in terms of their onset of being activated, whether early on or as the disease progression? And this is also very, very important. This is a new area we're looking at, neuroinflammation. Inflammation is the cousin of any disease, whether it's cancer, neurodegeneration, and so on. It's a step that happens along so many different pathology. So determining an early indication of neuroinflammation, and non-invasively in a comprehensive way, is an important and exciting area of work. Okay, so here's one example. This is a compound that's developed at Cambridge in the UK and uses fluorine-18, small molecule, positron emission tomography that binds to tau protein, specifically elucidates the tau activity within the brain. And I just want you to appreciate this example. So we have the images of F18 labeled AV in AD patient, in palsy condition, and in healthy subject. So as you can see, red is the maximum uptake. So red means I have more of the tracer. I have more tau binding in there. As you can see, this picture in the Alzheimer's disease, much, much higher uptake in different ages, including even in the midbrain, compared to less so here, but compared to the healthy individual, it's much, much less. So this is a great validation that the changes or progressive changes in the protein activity is detected with this radioligand as we progress into the dementia condition from normal. So this can be done with a patient probably spending about half an hour in the scanner, similar to a CT scanner or an MR scanner, and the patient receives an IV injection of the radiotracer, and the imaging takes about half an hour, but you spend more time doing image analysis, etc., after the acquisition of the study. Okay, you can go further. Now, in the old days, when we don't have these sophisticated imaging techniques, and particularly in preclinical studies, we used to sacrifice and take tissues and look at the uptake in various parts of tissues in here. Here now we can use sophisticated image analysis techniques, and we can determine, how much of the tracer in different lesions, different tissues, different areas. Okay, so this was only possible when we sacrifice animals or so on. But now we can do this even directly in patients in terms of using these sophisticated image analysis techniques. Okay, we can relate the uptake in two different regions. What's the picture in the midbrain versus the hippocampus, for example? And we could look at these are the controls in blue. Red is the mild AD or mild cognitive impairment, or the cerebral palsy. So you can see there is some relationship depending on which conditions we're looking at. But this is the kind of thing that you can do without relying on a sample that you take from a patient, or if you can, that is, or post-mortem. And look, so you can do this in a live picture, basically. You can also relate it to post-mortem data and look at other things. So we could look at tau, we could look at the uptake with the tracer. So the top panel here is an autoradiography. Autoradiography uses a radiotracer, a source of radiation to be detected, and that's what the fluorine-18 gives us there. And then it's as opposed to PET imaging, which doesn't have a good resolution, autoradiography have microscopic distribution. So I can take an image slice of what I imaged in the brain and then look at its micro-distribution within that tissue area. And we can relate it to other particular images, if you like, in different area of ATB, other type of parameter. And we can do it also in the cortex as well as in the basal ganglia. So this is, again, further validation. And this is used when we are trying to say this tracer is specific. It does bind what it's supposed to bind to. And that's why we do these ex vivo analysis, as I call them. Okay. So what if we combine? What would we gain when we combine different modalities? Because at the end of the day, there's a lot of things happening here, okay? There is chemistry, there is biology that leads to physical changes, cognitive changes, maybe peripheral parameters as well. So we're trying to combine things to get, basically the sum of the parts is better than each individual component. So here is a tau example of multimodal imaging. So basically looking at tau PET with functional MR in the resting state. So I have a picture of the MR, and I have a picture of the tau activity in this brain region. And these guys, this is a recent study, I think this year, if I'm not mistaken, that they wanted to show how is the tau picture is related to the neuronal networks. So they devised these networks in these colors in here and looked at their functional resting MR, how they are related to the tau activity. And they produced these maps in here, and you can superimpose them on the next slide here on the network, and you can develop these different maps of where the red represents the tau tracer activity in different conditions, and do it quantitatively as well. So you can go from here to here, maximum to lower value. So this is a more complicated technique to put together, but it does really show that we can look at pathology network independently from the image and then put the two together. And here's the picture of the tau pathology network here, and this is the seed network based on the library or brain atlas map, and you come up with something like this from the both the biology as well as the functional MR data that you have. Okay, so I'm going to leave you with some of this. I'm going to talk a little bit about this, and this is where one of the future developments is to image neuroinflammation, because that's an early aspect of what's going on. So what's the target? Translocator protein is a protein that gets upregulated when immune cells start invading, okay? So if we can develop a ligand that's specific for upregulated TSPO, then we can have a measure of that neuroinflammation at a particular time. In the old days, the first series of these compounds developed was this fellow here, PK11195, labeled with carbon 11. Again, it suffered from the same, although it had good specificity and sensitivity, but it suffered from the carbon 11 metabolic instability. And you have to do a lot of correction analysis besides the short half-life. Since then, other compounds with fluorine 18 and some with carbon 11 has been developed. This is now the compound that we make it here at VCU, and this is the most promising DPA 714, labeled with fluorine 18, very lipophilic, crosses the blood-brain barrier, and it does bind specifically to the translocator protein. So I think in the future, we're going to see more of these studies combined with some structural and functional imaging methods to answer really specific questions that is involved in the different subtypes of dementia, neurodegenerative disease. But this also has applicability in TBI and other brain types of pathology. TBI is really characterized by initial burst of neuroinflammation, and I think this tracer is now being investigated at UCLA and a couple of other places to look at that particular problem. So I'm going to leave it here, and I'll be happy to answer any questions, and thank you for listening. There are initial tries to answer the same questions, but with the advancement of the imaging techniques, etc., these become more fruitful.
So this is, for me, a comment as well as a question. This audience is a very clinical audience, and so we sometimes would order 5-fluorodeoxyglucose PET CT when we're not sure if we're dealing with, let's say, Alzheimer's disease versus some other form of major neurocognitive disorder, aka dementia, where the treatment might be different, right? Because we've been trained to think of acetylcholinesterase inhibitors as drugs that might help patients that have, particular Alzheimer's pathology, but might not be as effective in certain other kinds of dementia. And you actually can get approval for Medicare to pay for fluorodeoxyglucose scan as long as you answer 11 questions correctly. Well, there is a set of questions that determines it's about $3,000 if you had to pay for it yourself, right? But Medicare will pay for that scan if you clearly differentiate why you're asking for that. Right. And what we've been talking about here now is the possibility of future probes to look at what's going on pathologically in brains of people who have debilitating neurologic conditions that are affecting their cognitive function as we start to move closer to having actual treatments that we can apply. So this is a sort of a look right at the research capabilities that will likely transform clinical practice in the future, and a great insight into how the technological complexities of this require very specialized programs. The instability of carbon-11 was new to me, so I learned something about that today. And I'm glad to hear that we have some methods that may help us with this very challenging set of problems that our patients have.
Yeah. I think, I'm speaking sort of for VCU Richmond. Over the last 10 years or so, we have really put together some sophisticated capabilities that guys like you really should benefit from. It's maybe something, it's not always in the open, because at the end of the day, for me, we're doing the research so we can see its fruition on the ground, that patients will benefit from it. Physicians can really use these kind of tools and techniques to better manage these patients. So I think the advancement of the neuroinflammation ligands, the tau ligands, and will help us not just in terms of diagnosis and so on, but it's going to help us a lot in terms of targeted therapy. So people are touting anti-tau and anti-amyloid, et cetera. We need to know a way, do we actually modulate that target by that particular treatment? Well, otherwise, we don't know.
For instance, in current practice, we have been taught that Lewy body dementia is best not managed with antipsychotic medications. It's actually contraindicated. But when we're talking to a patient or their family, being sure that the patient has Lewy body dementia is not always that easy. We've been taught certain clinical signs to anchor our opinion to, and patients have come at least to see me. I don't know about the rest of the audience, have come to see me, and they've been told that they have this or that kind of dementia based on somebody's expertise. And it's not always that easy to separate out. And the same with frontotemporal dementia in terms of the management and the expectations of what's going to happen. It's somewhat different than would be the case with Alzheimer's disease or vascular dementia, right? So the ability to untangle those is sometimes helpful in a clinical sense, even though right now our drug therapy for the primary disease is kind of weak.
Sure. No, I agree. And I think I just want to add something else to what Peter has said in terms of there are certain things, with the advancement of science and so on, but we don't see like, quick translation, if you like. Now, I know you see a lot of patients with neurodegenerative disease, and especially new patients. So, for example, you ask for a blood picture as one of the things, to look at, analyze for. I bet you there is no analysis of zinc or copper or iron. And these now we have huge evidence in the literature that these play vital role. And they are micronutrients. They are essential for everything. They are responsible for the working of millions of proteins, millions of enzymes, transcription factors, but it's a very much understudied, under-researched area. So for example, in some of the studies that I do with my oncology colleagues now, we start to say we need the zinc level of patient A and patient B and patient B. In prostate cancer, for example, we see a huge depletion. In neurodegenerative disease, there is zinc depletion. So I think it's important that we should pay attention to that kind of thing. You know better than me what to order, but I'm just sort of, I think, encouraging people to look at sometimes the simple things in life that God made us to do. It's a balance, okay? The zinc and the copper and the iron, they exist in micromolar, but the range is so fine. If you disturb it somehow, and we have so many factors that disturb it, from the way we eat, the way we live, the way we so on, and I think that those are important things that could help better adjuvant therapy for these kind of patients.
I know that historically we've said that the only definitive diagnosis of Alzheimer's, for instance, is post-mortem, through an autopsy. Are you saying that we are getting very close to as rigorous a definitive finding? And if so, how soon might we be able to tell this to patients so we can act proactively and perhaps enhance the remaining years before the full expression of the disease? Because there is that lag time between having the set of characteristics and then having the symptoms.
Right, right. Well, that's a good question, and the answer may be beyond my knowledge and capabilities in this. But I think we are closer now than many years ago in terms of trying to use these tools to look at the individual's case, if you like. They all present with different subtypes. They may have other associated things, but I'm not really sort of fully aware of it. I mean, a question like this could be, directed to one of my colleagues, for example, Jim Bennett, who's a PD person, and will understand that better. But I do agree with you, yeah.
Okay, we've got you guys a little extra time for a break.
Thank you.
We'll reconvene at 3:15.